Today's topic, impacted third molar. Contents is shown in the screen. Introduction. Definition by Archer. Impacted tooth is one that failed to erupt and will not assume its anatomical arch relationship beyond the chronological eruption date. All impacted teeth are unerupted or partially erupted. Common maxillary and mandibular third molar and maxillary canine. Local causes of impaction: lack of space in the dental arch, obstruction for eruption, dilaceration of roots, over-retained deciduous tooth, density of overlying bone, ectopic position of tooth bud. Systemic causes for impaction: prenatal cause, hereditary example; postnatal causes, rickets, anemia, congenital syphilis, malnutrition, tuberculosis, endocrine dysfunction, cleidocranial dysplasia, osteopetrosis, cleft palate. Frequency of impaction: mandibular third molar, maxillary third molar, maxillary cuspids, mandibular cuspids, mandibular bicuspid, maxillary bicuspid. Indication for removal of impacted tooth: recurrent pericoronitis, recurrent pain, recurrent infection. Deep periodontal pockets to prevent the caries to both the wisdom impacted tooth as well as the neighboring second molar, to prevent the crowding by anterior component of force, management of cyst and tumor, prevention of pathologic fracture in case of idiopathic pain, to prevent the pathologic resorption. The contraindications for removal: when it is used as an abutment for FPD, when no history of bony pathology, suspectability of fracture while removing tooth, tooth which likely to erupt successfully. Classification of impacted tooth: first classification by Winter, which is proposed in 1926, according to the position of long axis of third molar in relation to the long axis of second molar: vertical, horizontal, mesioangular, distoangular, buccoversion, linkoversion, and inverted. Diagram showing all these positions. The second classification is a modification of Winder's classification proposed in 1933 by Pell and Gregory. Modification of Winder's classification based on three components: availability of space between second molar and ramus, that is the horizontal plane; relative depth of the third molar, vertical plane; long axis of the impacted tooth in relation to the long axis of second molar, angulation, that is Winder's classification; relation of tooth to anterior ramus of mandible and distal side of the second molar, that can be classified by class 1, class 2, class 3. Class 1 means sufficient space exists between the distal aspect of second molar and anterior border of the ramus to accommodate the mesiodistal diameter of impacted tooth. Class 2 means space between the distal aspect of second molar and the anterior border of ramus is less than the mesiodistal diameter of the impacted tooth, hence it is partially buried in the ramus. Class 3, no space is available, tooth is buried in the ramus. Based on the relative depth of the third molar in the bone or in relation to cemento-enamel junction of the second molar, it can be classified as position A, position B, position C. Position A, highest point of impacted tooth is in level with the occlusal plane. Position B, highest point of impacted tooth is lower than the occlusal plane but above the cervical line of second molar. Position C, highest point of the impacted tooth is below the cervical line of second molar. Radiographic examination, basically intraoral, then IOPA, occlusal, bite wing can be used. The extraoral X-rays used are OPG, lateral oblique. Intraoral X-ray, position and depth of the tooth can be assessed by taking intraoral X-ray and tracing imaginary lines originally advocated by George Winter. These imaginary lines drawn, which are known as Winter's line or war lines. The white line corresponds to the occlusal plane. Line is drawn touching the occlusal surface of first and second molar is extending posteriorly over third molar. This indicates the difference in occlusal level of second and third molar. Amber line represents bone level. Line is drawn from the crest of the interdental septum between first and second molar and extending posteriorly distal to third molar or to ascending ramus, denotes the alveolar bone covering impacted tooth and portion of tooth not covered by the bone. Red line, it is drawn perpendicular from the amber line to imaginary point of application of elevator. It indicates the amount of bone that has to be removed before the elevation, and it relates to the mesial aspect of CEJ of impacted tooth. Armamentarian use instruments for cutting of bone and tooth, elevators and forceps, instrument for incising and removing soft tissue and debridement and suturing the wound. Operative procedure, odontectomy, removal of partially erupted or unerupted tooth or retained roots that cannot be extracted by forceps technique and therefore must be removed by surgical excision. Soft tissue impaction, it can erupt into normal occlusion. Overlying flap is removed, that is operculectomy. Bony impaction, two methods. A bone is excised to permit the removal of the tooth in one piece. Second method is tooth section so that it can be removed in parts, that is odontotomy. Tooth division technique is by Pell and Gregory, 1942. Advantages: less operative pain swelling, less chance of damage, risk of fracture of the jawbone is reduced, injury to inferior alveolar nerve is greatly reduced. Surgical removal of impacted tooth. The procedures are asepsis and isolation, anesthesia, incision, flap design, reflection of mucoperiosteal flap, bone removal, sectioning, elevation and extraction, debridement and smoothing of the bone, control of bleeding and closure, suturing, medications, antibiotic and analgesic, and follow-up. Usually anesthesia in a mandibular third molar is by inferior alveolar nerve block or a mandibular nerve block. GA is also recommended when the difficulty of impaction is more. Incision flap. Ideal flap requirement of mucoperiosteal flap is it should provide adequate exposure of operative site. Incision will have anterior, posterior and intermediate limb. For mandibular molars, anterior releasing incision should begin from the vestibule upward towards the midway of the EJ of the second molar, and incision is continued in the gingival sulcus up to distal aspect of the third molar. Distal releasing incision is started from the distalmost point of third molar across the external oblique region to buccal mucosa. The types of incision: envelope, triangular. Envelope flap. Flap extends from the mesial papilla of the mandibular first molar and passes around the neck of the teeth to distobuccal line angle of the second molar. Incision line extends posteriorly and laterally up to the anterior border of the mandible. Advantage: it is easier to close and heals better. Triangular flap, it is indicated when in cases where the impacted tooth is deeply embedded in the bone and require extension of bone removal. Elevation of flap is usually done by a periosteal elevator to allow an adequate exposure of bone and tooth. After the elevation of buccal flap, lingual soft tissue must be reflected, done by inserting the elevator under the periosteum and pass in a distolingual direction to reach the lingual border of the mandible. Once flap raised, the retractors is used to retract the flap. Bone removal can be done in two ways. One, high speed, high torque handpiece by burr technique, other is chisel and mallet technique. Burr technique, usually number 7/8 round burr or straight Fisher 703 burr used with saline irrigation. Burr should be used in a sweeping motion around the occlusal, buccal and distal aspect of third molar. Once the crown has been located, the buccal surface of the tooth is exposed with birth tooth cervical level of the crown contour and gutter is created. The maximum bulk is exposed. So diagram showing the birth technique, tooth sectioning and elevation and extraction. Reduce the amount of bone removal prior to elevation of the tooth. Reduce the risk of damage to adjacent teeth. Planned sectioning, a traumatic removal of a tooth can be done with a burr or chisel. Direction of sectioning is dependent on angulation of impaction. Sectioned piece should be ideally have a narrow base for easy removal. Elevation using Coupland, Winder or Cryers. Tooth division technique avoids removal of large amount of bone, avoid disturbance of adjoining structure. Lingual split bone technique is remove any impacted tooth lingually placed. Mucoperiosteal flap is raised by standard method. Remove the distolingual bone by placing a 5 mm chisel distal to third molar. By twisting the chisel bone splits obliquely backwards, a wedge-shaped bone is removed. Tooth is elevated and delivered in the lingual direction. The flap is sutured. Then the debridement and closure of wound. Irrigation of socket, curate and remove remaining dental follicle and epithelium. Check for remnants of tooth, bone, granulation tissue, bleeding points. Round off the margins of socket with round burr or bone file. Irrigate socket again. Control bleeding before suturing. Closure, usually 3-0 black silk is used. Interrupted suture is given. Maintained for 7 days. Suture distal to second molar placed first and should be watertight to prevent pocket formation. Complications. Operative complication, post-operative complication. Operative complication, injury to inferior alveolar nerve and lingual nerve, root fracture, injury to second molar, breakage of instrument, fracture of the mandible, injury to lip, cheek, tongue. Post-operative complication, secondary hemorrhage, infection, dry socket, pain, trismus, ecchymosis. Thank you. Stop recording.